Good morning and welcome to Southern Maine Healthcare's Medically Speaking. I'm your host, Robert Erickson, and for the next 30 minutes, you'll hear about medical issues and topics of the day directly from leading medical professionals at Southern Maine Healthcare. Thank you for tuning in to Medically Speaking. I'm your host, Robert Erickson. Our guest today is Dr. Meredith Mayo, who specializes in sports medicine surgery at Southern Maine Healthcare. Welcome, Dr. Mayo.
Thanks for having me, Robert.
We like to start out with a little bit of background first. Tell us a little bit about how you got involved in medicine, and then how did you decide to specialize in sports medicine?
I actually only went to medical school to do orthopedic surgery and thought even in high school that I wanted to do sports medicine surgery specifically. I played a lot of sports growing up, specifically soccer, and saw a lot of people get injured and wanted to help them and people like them get back to the things they love to do.
Now, this is a field that's changed dramatically in recent years. Sports medicine itself is now a specialty. How did that happen? How did the evolution happen over these last few decades?
The specialty really became unique when the invention of arthroscopy happened. And now it's been about 50, 60 years since this has been going on, and it has evolved due to the changes not only in the technology associated with arthroscopic surgery, but also with the implants and biologic research. Things have really evolved, in a 5 to 10 year basis dramatically.
Can you talk a little bit about the difference between a traditional orthopedic surgeon and a sports medicine surgeon? What's the difference?
Sports medicine surgery specifically involves arthroscopic or minimally invasive procedures that are generally geared toward joint preservation as opposed to joint replacement. Joint replacement is a much larger part of a general orthopedist or joint replacement surgeon's practice, whereas in my case, I work with patients trying to preserve their native joint or natural joint to prevent them from having to have a joint replacement.
So what sort of patients do you normally see?
So I see people of all ages. I think so far in my practice, my youngest patient has been 2, and my oldest patient has been 99. And so I do still do a small amount of general orthopedics, but sports medicine doesn't necessarily mean that you're an athlete on a college team. It can mean that you really enjoy your leisure activities and you've had an injury that set you back and prevented you from being able to do that. Also, really in our community here in Maine, there are a lot of manual laborers who are just as hard on their bodies, if not more so, than athletes. And getting them back to their jobs is a big part of my practice as well.
I'm just curious, what kind of work would you do on a 2-year-old?
Oh, I think the 2-year-old I had simply had a small fracture that didn't need surgery, so it was just casting and monitoring them.
So what part of your job do you find most challenging? What kind of work with patients do you find most challenging?
Well, I think this is a community of very motivated people, and people want to get back to work or back to sport right away. And I spend a lot of time talking to people not only about what the surgery entails, but even more importantly, what the postoperative rehabilitation protocol entails. And it's not always an overnight recovery. And so I think giving people a realistic expectation of their time out of work or out of sport has seemed to be the biggest challenge so far.
So we often hear about fellowship-trained surgeons. And you are fellowship trained. Maybe explain to the audience a little bit about what does that mean?
Sure. So after medical school, I did 5 years of general orthopedic surgery training. And then after that, I elected to do an additional year in sports medicine surgery. The program that I went to at Stanford University was about 75% arthroscopic procedures, primarily of the knee, shoulder, and hip. And then I also did 25% of my time there focusing on shoulder replacements, which traditionally has gotten bundled into sports medicine fellowships because as people have exhausted their minimally invasive procedures for the shoulder replacement becomes one of their options as well.
Now, for some of the listeners out there, particularly the older listeners, maybe explain what do you mean by minimally invasive surgery? In the old days, that term really maybe wasn't part of the lexicon of sports surgery. What does that mean by minimally invasive?
So the incisions required for a purely arthroscopic procedure are each about 1 centimeter in length. And depending on which procedure you're having in the knee or shoulder, you could have anywhere from 2 of those to 4 of those.
So how does that work for a surgeon? What are you looking for when you, well, maybe talk a little bit about, say, knee surgery. What are you looking for with an incision like that?
One of these small incisions is used to put in the camera or arthroscope that allows you to see throughout the joint. And then anywhere from 1 to 3 additional small incisions are utilized to allow you to put your instruments in and manipulate tissues from the inside. And the instruments have become fairly advanced, where they're very nice, they're very small, so they fit through these small incisions and allow you to do procedures that otherwise would have required, like you mentioned, a larger open procedure in the past.
So it has a lot less effect on the muscles?
Correct.
So one of the things I'm getting at here is how minimally invasive are some of these procedures? Could you do a comparison of maybe what it was like 25, 30 years ago for recovery? I'm assuming we didn't have the same kind of same-day procedures that you have today.
Specifically in the knee, because I think that the knee procedures have evolved the most over time in terms of recovery. So 99.9% of my procedures, apart from shoulder replacement, are outpatient procedures. So you're in and out the same day. The surgeries are usually anywhere from 1 to 2 hours max. And the recovery usually involves getting up and walking that same day. Most patients actually walk out of the post-operative care area in the hospital. Often do require crutches just because you're a little wobbly from all the medications and from having the procedure. But unless there's specific weight-bearing restrictions from the procedure that I did, people are walking normally within 2 to 3 days. And oftentimes when I see people by the 2-week mark, they don't require crutches at all.
So orthopedic surgery is, depending on the age, is very complex in the sense that you can get any joint replaced these days. Is that correct?
For the most part, yes.
So tell us a little bit about your specialty. What sort of procedures do you do? What's your core area of interest?
So I am extremely interested in the knee, and particularly in our community here in southern Maine, there was no one in our immediate community that was doing knee preservation procedures. And so that's a big passion of mine. What that involves specifically is doing meniscal repairs, addressing specific cartilage lesions, which are almost like potholes within the cartilage of your joint. And there are multiple ways that we can do that. Also for people who've had more significant injuries, either in a car accident or in a sport where they've torn ligaments in their knees, ways to do ligament reconstruction.
So probably the most difficult thing for somebody listening to this is they might say, when do I go in? I've had friends who've had surgery before, but I'm just not sure if I'm at the right time. Depending on your age, how does a patient gauge when it's time to come see you?
I think if you notice that you're being limited on a consistent basis or daily basis, it never hurts to be evaluated sooner rather than later. The worst you're going to be told is that you're fine and that you didn't necessarily need to come in or you don't need any further treatment. But that gives people a lot of peace of mind, and then they can proceed and get back as they feel comfortable. I've actually done a lot of research during my residency about how much additional knee damage can be sustained from a missed ACL injury, particularly in young patients. So I always urge people to come in so that they don't develop additional injury.
And that was one of my questions. Why is it important to be diagnosed early for a young athlete?
Yeah, so the study that I really participated in, and we got about 5 publications out of our patient data, and this was patients anywhere from the age of 5 to 18 who had sustained ACL injuries. And we looked at a number of factors, including not only their specific age within that age range, but also the time at which they presented for initial orthopedic evaluation. And we noticed specifically if they had come 6 months after their initial injury that they had a 40% increased chance of having either a meniscus or cartilage injury in addition to the ACL injury.
And why would that be?
The ACL is the primary stabilizer of the knee, particularly with rotation. And once you lose your ACL, the meniscus, specifically the inside meniscus, and the knee becomes your secondary stabilizer. So it receives an additional amount of stress than it's accustomed to in a lot of people, and that can cause tearing.
What are the most common injuries that you see among high school athletes, say? And is there a difference between what you see in young men and young women?
I don't see a huge difference between men and women per se in the high school population. It seems to be more sports specific. So I think for sports that are more focused on throwing, things like baseball, lacrosse, football, if you're a quarterback, people tend to have more shoulder injuries as well. Swimmers also would fall into that category. So I'll see things like shoulder instability or tendonitis within the shoulder in high school athletes. Also, unfortunately, high school athletes can dislocate their shoulders from impact, and so we see those patients as well. In terms of the knee, it seems to be more common in football players from the high level of impact to their knee, as well as basketball, track, soccer, any sport where you're really running and cutting on either turf or a basketball court can cause significant knee injury.
Now, I'm showing my age a little bit with this question, but with the advent of AstroTurf and artificial surfaces, are the injuries different? Is natural turf, is that better for athletes?
That's a pretty hot topic in sports medicine, particularly in studies associated with injuries in soccer players. And many people in the sports medicine community believe that AstroTurf actually puts you at increased risk for sustaining knee injury. The thought is that there's increased friction in the AstroTurf as opposed to a natural surface. That causes you to either get your foot stuck, or if you sustain an impact, your foot doesn't move as quickly off of the AstroTurf.
So let's talk a little bit more about high school athletes. What would your advice be for parents who maybe are worried about their child incurring joint damage, but then they're really not sure if it's just growth or it has something to do with the sports that they're playing? What would you say to those folks?
I think one thing that works very well with my job at Southern Maine Healthcare in this community is we have such a close relationship with not only the Sports Performance Center, but also the affiliates of the Sports Performance Center, specifically the athletic trainers that are really integrated into the high schools in the community. I'm in close communication with the trainers from each of those high schools. We text and email frequently, and so I think that's the easiest step for parents. If they don't have to make a trip to the office, if their child can see the athletic trainer at their middle school or high school, they can usually get tied in through our entire system and team, and I'll talk with those athletic trainers and see if they feel like the patient needs to be seen in the office. I'm always happy to see them, and my goal is to get those people in within 24 hours if the athletic trainer has any concern. The same is true if they're people who are going to physical therapy at the Sports Performance Center. The physical therapists are very communicative. If they have a patient who's not progressing or seems to have a more advanced injury than what their original referral to physical therapy was for.
Now, we're a very sports-oriented culture, and there are parents who like to encourage their children to get into sports early. Do you have an opinion on the age of young athletes who maybe are beginning to play sports and the effect that it might have on their growing joints as they get older?
The best guidelines that we've found in our sports medicine community is not so much whether or not kids are getting into sports. It's kind of two main things. One is to balance the sports that they're in. So kids who are in one sport year-round with minimal breaks and not participating in other sports are at increased risk for injury because they're constantly using the same muscle groups and performing the same kind of movements. If kids are diversifying their athletic participation, they're overall better athletes even at one individual sport. And so I do recommend that parents diversify their kids throughout sports. Obviously, if you're really getting to an elite level in high school and need to focus your time on one sport, then that makes sense. But especially as kids are growing up and their growth plates are still open, it's best to diversify them as much as possible. Also to provide them a period of rest throughout the year.
Now, you've been doing this for a while. What kind of advancements have you seen in surgery, and what do you see coming down the road? I mean, what kind of advancements are in the works?
So in sports medicine specifically, there are significant advancements. It seems like on a monthly basis, reading about new implants that are getting smaller and stronger as we can make technological advances in the materials that are used in the implants required for reconstructive surgery or repairs. And then a whole nother category of research in sports medicine is really centered around biologics. And I think that will be a big part of our field in the future. I think that the research overall is a bit limited in our country due to our regulations at a national level, but also we just haven't learned the best way yet to manipulate some of the tissues and cells to best do things like ultimately replace cartilage or prevent or reverse the progression of arthritis. That's really the gold mine and long shot in orthopedic research. If we can ever manipulate cells or tissues in a manner that can safely reverse or prevent progression of osteoarthritis or knee arthritis, hip arthritis, that would be life-changing for our patients.
You're listening to Medically Speaking, and we are talking today with Dr. Meredith Mayo, who specializes in sports medicine surgery at Southern Maine Healthcare, and we'll be right back with more of our discussion right after this.
For high-quality walk-in care, the best team is always on the ball. Look for Southern Maine Healthcare's Orange Walk-in Care Ball. With convenient locations open every day, it's your guarantee of quality walk-in care delivered by your hometown team.
And we're back with our guest, Dr. Meredith Mayo. Do you think the active lifestyle that people lead today leads to more stress on the joints and then thus leads to more joint replacement procedures?
So it really depends on whether or not they've had an underlying injury. For someone who has not had an underlying injury, the risk of progressing cartilage wear or arthritis is not increased. In some studies, it's actually shown that you build more cartilage, specifically in the knee, if you're a long distance or consistent runner, because you're receiving more impact, your body responds by building more cartilage. The challenge is once you've had an injury to the joint, whether that is a cartilage defect or some other injury, dislocation, something like that, and you're predisposed to arthritis for those reasons, then high impact activity like running, jumping, long distance endurance activities can cause additional and premature wear on your joint.
So for the older athlete who wants to stay active, what are the differences between now and, say, 25, 30 years ago for people who want to stay active and be running marathons in their 50s and 60s?
Right. So when you get to the either level of maybe having mild arthritis, but you want to stay active, those are the types of patients that I think can really benefit from all of our non-operative measures for optimization, which do include things like physical therapy or even having a personal trainer to focus really and truly on getting you to your specific sport or activity. Additionally, we do have injections that we can utilize in the office that can provide you midterm relief for your joint pain and delay and often avoid joint replacement in many patients.
So what are realistic expectations of people who want to maintain high-level activity in their 60s and 70s? Of course, that has a lot to do with personal health, but do you see any limitations for people who want to maintain that kind of active lifestyle?
No, I want everyone, even my 99-year-old patient, to be able to do what they want to do. Who am I to say that you're too old or too young to be able to do what you want to do? So oftentimes, I think people's treatment plans need to be very tailored to what their goals are. Sometimes I've had shoulder patients who say, all I want to do is be able to knit. And then you're like you've mentioned, I do have other people who say, no, I need to be able to run this marathon or half marathon. So it really can be specific to the patient.
Have you had any particular instances in your career that have really inspired you? Are there any stories you could share with us about patients that you've had that have come back from really tough injuries?
Yes. During my fellowship, I helped take care of a woman who is now a national team player for a sport that had a significant knee injury, and she had a long recovery after a major surgery and came back, and her senior year of college won the national championship in her sport. It was truly inspiring to see how not only patient she was, but also resilient and committed to her rehabilitation. I think her story and ones like those speak to how important rehabilitation is.
So what surprises you as a sports medicine specialist about the human body?
How quickly people recover. I think it's truly incredible how quickly people can feel better after a major surgery. That may not mean just because they feel better that they're immediately able to go do what they want to do, but even just to feel better is such a relief for so many patients.
So maybe you could be a little specific now about the areas of interest that you have and the procedures that you do.
I love to do arthroscopic surgery of the knee, shoulder, and hip. In the knee, that would entail addressing any ligament tear like we've talked about and doing a ligament reconstruction like the ACL most commonly. Additionally, doing meniscal repairs or, like we mentioned, cartilage preservation procedures for specific focal chondral deficits in the knee. In the shoulder, I most often take care of patients who've had dislocations or instability episodes and either are having recurrent instability or having recurrent shoulder pain from their dislocation. And then a large portion of my practice is also taking care of patients anywhere from the age of 30 to 80 who've had significant rotator cuff injury in their shoulder. This is extremely prevalent in our manual labor population here in southern Maine. And lastly, in the hip, taking care of patients who have really symptomatic labral tears, which is one of the supportive structures in the hip joint that have not done well with therapy or non-operative management. The last portion of my practice is shoulder replacement surgery.
So when someone has a repair or a reconstruction, I'm sure they're very careful at first, but then you get into your lifestyle, and how long will these recoveries last for most people?
The longevity is not an issue. The goal of the surgery with the appropriate rehabilitation is that you never have to have an additional surgery, which is great for patients. The challenge becomes sometimes that rehabilitation can take some time to appropriately get your muscles surrounding the joint optimized to be able to support the joint and make things as safe as possible when you do go back to your activity or sport.
Now, is it normal for people to be nervous about using the joint the way that they used to use it?
It can be. I think specifically in the knee, it can feel different after you've had something like an ACL reconstruction, but that's where, especially when you get to the end of the rehabilitation process, the Sports Performance Center specifically is excellent at doing what we call return to sport testing. So they slowly progress you through activities that are specific to your sport, running, cutting, things like that. So you really go through this whole protocol in a protected environment before you're kind of cut loose back to your sport. And I don't let people get back to sport until they've passed those tests in the office.
Now, in a nutshell, can you walk us through a little bit about a regular surgery, maybe a knee or something else, and the entire process that takes, and also what people need to do to get back to where they feel normal again?
Sure. Sometimes I see people, one day after their injuries. Sometimes I see people who've already been evaluated and worked up. Oftentimes for arthroscopic surgery, we do require and need an MRI for preoperative planning. So usually it takes 1 to 2 visits to make sure we have all of the appropriate imaging to make the right operative decision for the patient. And then once we have all the pieces of the puzzle, I have a long conversation with the patient about their spectrum of options. You never have to have orthopedic surgery, so I kind of always start with that to give people a little bit of comfort if they're apprehensive about having surgery. And then if there are any intermediary options, I propose those to them. And then obviously the most invasive option is surgery, which is sometimes scary for people. So we talk through that, and then we schedule their surgery once they've agreed on it, if that's what they choose. The surgery day, they usually come in about an hour and a half before the procedure and leave about an hour after the procedure. Like I mentioned, my procedures are about anywhere from 1 to 2 hours for the most part of actual operating time. So overall for the patient, it ends up being less than, 1 day in the hospital. Their recovery, it is surgery. People are uncomfortable for 1 to 2 days after surgery, I would say, for the most part. And then usually by 1 week after surgery, they're feeling well, not requiring many medications. And then I see patients 10 to 14 days after surgery for our first post-operative visit. In a lot of patients, they get into physical therapy even before my first visit with them to start working on range of motion and strengthening. So it's a pretty quick reintegration into the rehabilitation and recovery process.
So what does it feel like for the patient when they come out of the procedures? Does it feel different?
Not necessarily. I don't think that people feel different. A lot of our implants are so small that they certainly can't feel the implant. That would not be an ideal implant. But you do, they have had incisions, so they have some pain from the incisions initially. But overall, no, I think if anything, once they're through that initial recovery from the inflammation that's caused by surgery, they feel much better.
Now, does most insurance cover some of these or all of these procedures?
My experience has been all of them. I have not yet had one patient who's been denied by an insurance company for surgery that I've recommended.
Now, if someone's listening to this and they want to find out more about you or get in touch with you, what's the easiest way for them to do that?
Sure. So I'm currently both in Biddeford primarily and also in Sanford. And our phone numbers at each of those offices, the Biddeford phone number is 207-283-1126. The Sanford office is 207-324-1488. And both of those offices are open 8 to 5, Monday through Friday. And our staff is excellent, very good at communicating not only with the physicians, but also helping patients get in quickly when they need to be seen. We really focus on trying to get people in the same day that they call if they're interested in that.
And one final question, do patients need a referral from their physician to come see you?
We do not require referrals. That sometimes is dictated by their insurance, however.
Well, Dr. Mayo, thank you for being on the show. We appreciate it.
Sure. Thank you, Robert.
Join me next week at this time for a new guest and an enlightening discussion about healthcare in our communities. Brought to you exclusively by Southern Maine Healthcare, your trusted resource for healthcare in Southern Maine.